and very, very happy and very honored to be here again. So my name is Gyula Tövisházy. I'm from Budapest, Hungary. I work partly as a pediatric anesthetist at Szemmelweis University, Hungary, and I'm also medical director of our specialized pediatric retrieval service called St. Martin's Ambulance. And today I'm here to talk to you about vascular access complications. And this is the three main topics I prepared. So first we are going to talk about peripheral IV lines in general, then some cases, some interesting cases about extravasation and extravasation injuries due to IV lines. And third, maybe some news about intraosseous access. So I hope it's going to be useful, and I'm happy to have any questions during or after the talk. So, but first, could you please answer with using the YouTube chat? Could you please answer this question? My first interactive question is about first attempt success rate. So, what is the first attempt success rate in pediatric peripheral IV access in general? Is it 24%? Is it 39%? Is it 50%, 65%, or 83%? Obviously, this is a difficult question, and it depends on lots of things. I'm curious about your thoughts and hope this works well technically. I now wait for another 5 to 10 seconds so that everyone who wants to vote can submit their votes. And let's see what the poll looks like. So it's still working, but as I see, most of the people voted on C. Let's see what my answer is. Actually, I agree. So at least according to these two articles I found about this subject, only around 50% of our first attempt at peripheral IV cannulation is successful. I think it's quite a shocking number because if you take into account what first attempt success rate do we accept at airway management like intubation, 50% is quite poor, and obviously, as I mentioned, it depends on lots of reasons. One of the articles is something to do with ultrasound-assisted venous access, and we will later show that it can improve these results, but generally this 50% is unfortunately true. Obviously, there are difficult patient groups who are very difficult to cannulate, like these healthy, chubby infants. But there is a term in the literature called DIVA, so difficult IV access patients, who are even more difficult to cannulate. I think everyone knows them in their neighborhood, especially who works in tertiary pediatric centers. For example, premature babies, cystic fibrosis or short bowel syndrome patients belong to this group. Hemato-oncology, chronic renal failure, or babies after cardiac surgery can also pose a very significant risk of having difficult IV cannulation success. If you use an ultrasound, it's a very nice thing and very powerful thing to do, I think, but there are certain very important considerations. As in this picture, you see that the operator prepared a very easy ergonomics, which means that they only have to look down on the IV line or up to the screen, but no turning of the head is required. And I think it's the preparation and ergonomics is even more important in this topic than how skilled you are with your hands. Also, I found it important that it's no team sport, which means that the same person should hold the ultrasound transducer who are holding the cannula as well, because even with one person, this coordination is not so easy. So I think it's important for it to be in the hands of the operator. Maybe you will need a longer cannula than expected. For example, on this baby, he doesn't need a pink cannula from any clinical standpoint. We only chose this one because it's long enough, and we hope that it's going to not only reach the vein, which is lying quite deep underneath the adipose tissue, but there is also going to be some space for the cannula to be advanced. Also very important not to start on patients, but to really use of ultrasound phantom first, and only if you are very comfortable and completely signed off about these procedures, then you can proceed to a real patient, I think. Let's see some cases about extravasation. My first case, which happened a few years ago, was a 12-year-old boy undergoing alveolar bone grafting, so a maxillofacial surgery due to cleft lip and palate. The surgery and the anesthesia was also quite uneventful, but after 1.5 hours, unfortunately, an extravasation of both the propofol and the crystalloid infusion was noted. If we take a look on the images, I think they are quite shocking and quite disturbing, but luckily, as you see, we put on a pulse oximeter probe on the finger. It showed a very good perfusion distally, and luckily no surgery was needed. This swelling and this painful discoloration resolved until the next day and improved quite significantly, and no surgical input was needed. Although I'm not really used to any of these conservative issues, I'm curious about your thoughts and what the panel can add, because on this Australian guideline, I found some interesting conservative management options, like this so-called washout procedure, and also 2 medications which can help, although phentolamine is more involved in cases where vasoactive substance like noradrenaline is extravasated. If someone is interested, I put in a QR code which leads to this Melbourne website. This is a very useful input, I think. But let's switch to case number 2, which is a 10-year-old girl we managed recently. She has liver failure due to portal vein thrombosis, and she presented with a massive upper GI bleed, needed transfusion, needed octreotide infusion, and also underwent an acute upper endoscopy with endoscopic varix ligation. The next day, she was transferred for a CT angiography, and she also needed some inhalational sedation for this, even for this short CT scan. Unfortunately, the contrast material extravasated, and so by the time she was transferred back to our department, the dorsum of the left hand looked like this, which was very painful as well. And this process was quite heading into the wrong direction. So our plastics team was consulted, and compartment syndrome was diagnosed, and a very urgent fasciotomy and negative pressure wound therapy, so vacuum therapy, was instituted. The wound could only be closed after 6 days, and luckily the complete function of the hand is restored, but the patient needed quite long physiotherapy and long-term follow-up. So this is really a long-term issue, and this is something we really have to pay attention to. The third case is unfortunately also a very bad thing from several years ago. This was a preterm baby receiving total parenteral nutrition because of having multiple abdominal surgeries. This day, his central venous line was malfunctioning, was dislodged, and for a temporary few hours, unfortunately, a decision was made to switch the whole parenteral solution to a peripheral line, which was unfortunately a bad decision and ended up in such a significant extravasation of high osmolality glucose, amino acids, and lipid solution, which also needed surgery, exploration, and delayed wound closure. Luckily, this wound also managed to heal, but this was a quite awful time for the family, as you see. This table shows a very nice picture of the different solutions, different medications, putting into three categories. So as you see, in the green box, these medications have a lower risk of tissue injury in case they extravasate. The yellow table shows you an intermediate risk, and inside the red box, you see very high risk solutions. I would emphasize cyclovir, calcium, and any high osmolality solutions like TPN, like in the third case. But as this green box highlights, unfortunately, no intravenous infusate is considered to be safe. Even normal saline can cause problems in case there is a too high pressure and in case there is a compartment syndrome. It can cause significant injuries. So we really have to focus on prevention. And I found a very important and interesting input from UK's NIVAS, so National Infusion and Vascular Access Society, which on their posters and flyers, they highlight the importance of this topic about prevention, early recognition, and in case it's needed, so in case the so-called high-risk solutions, vesicants are extravasated, an early plastics or surgical input and consultation can be needed. So if you notice a child who has a running infusion and develops pain, swelling, dark necrotic skin or blisters and erythema, you want to make sure that there is no dislodgement or no tissuing happened around the cannula. Let's see the last topic, which is about intraosseous access. And maybe I'm going to tell you some news about the recent years. I borrowed this nice image from Don't Forget the Bubbles website, which shows you the locations where we, as pediatric emergency providers, can choose to put an IO in. So the IO cannulation sites. Probably you and our service also is most familiar with the proximal tibia, which has a very nice medial flat surface, and 1 to 2 centimeters from the tibial tuberosity below, you can put it in very easily. But there are also other sites. The distal femur is one of them. The distal tibia is another of them, and the humeral head is also a possibility. I think it's more used in adults, but in case the child is more than 6 years old, or in case there is trauma of the lower extremities and the pelvis, which would mean that the tibial IO line would not be appropriate, you can choose the humeral head as well. It's a bit different, and you have some certain aspects for palpation and the cannulation direction, but it can be very useful and very successful first aid. This short video shows you how effective and how successful correctly placed IO line can be, because the contrast material reaches the femoral vein very quickly, and actually it acts as a central line. But let's see what really matters. So what sizes and what locations you should use. The manufacturer of the most popular device, Easy IO, with which I have nothing conflicts of interest to have. So the manufacturer of this Easy IO device has three needles. The pink one is 15 millimeter long, and it's theoretically it's advised for patients between 3 and 39 kilograms, which I think is a quite broad range. The blue device is the blue cannula is 25 millimeters long. The yellow one is 45 millimeters long, and in the recent 5 to 10 years, we had a clinical experience and an impression. Several providers of our service had this impression that the typical 1-year-old baby who needs an IO line because of a cardiac arrest or a septic shock or something like that, in this patient, pink line is not enough, and we had lots of problems with dislodgement and extravasation, and maybe this was due to this needle being too short for this population. So what we did was do some literature research and found two very useful articles, which I'm going to present you in the next slide. But the manufacturer also suggests that before starting to drill, at least 5 millimeters from this needle should be outside the skin, which would mean obviously that in case it's not appropriately sized, then you have to open another needle, which is quite expensive, I think. So what these two articles say, which were actually radiological observations about X-rays taken from several babies and children. This article shows, without going too much into detail, that more than 10% of the so-called appropriately sized needles didn't even reach the medullary cavity. This other article coming from Canada also shows us that if you change from a pink to a blue needle, which is longer, then you can save lots of extravasations because of the pre-tibial fat pad and the pre-tibial soft tissues. So because of these two articles and because of our own experience, we decided to do an arbitrary limit change. So what we do nowadays is only use a pink one for babies younger than 6 months. For every child older than 6 months, we use a blue one, and for adults or obese teenagers or humeral access, we tend to use a yellow one, although obviously we don't at every occasion put it to the full length, of course. Let's see what complications can an IO line have. As mentioned previously, an extravasation is quite a significant and quite frequent issue, unfortunately, and improper placement or improper size choice can be a very important cause of it. Infection and osteomyelitis is quite rare, but that's the thing why all of the guidelines suggest that an IO line should be removed as soon as possible. And there's two other questions I would like to mention. The first one is in case you have to put in an IO line, so an intraosseous line to a patient who is awake, then you have the issue of analgesia. This is obviously not a very frequent situation because most of IO lines are put in during cardiac arrest or unconscious patients, but there are some situations where you have to do this. And this German article and this German working group issued a statement about intraosseous lidocaine, because previously even the ERC suggested intraosseous lidocaine infused slowly into this cannula to prevent the injection pain, which is quite significant. But these German colleagues published three cases. I'm not going to go into this German details, but they wrote down these three cases which were involved in the death of three children, which was every one of them was associated with local anesthetics getting into systemic circulation. Although I think it's a bit not so clear, because these causes involved even not only lidocaine but also mepivacaine, which is a highly cardiotoxic solution, and also there were some issues with medication safety with very high doses, but still they actually banned intraosseous lidocaines for safety reasons. And if you take a look at the newest guidelines of ERC, they don't specifically ban, but also don't recommend intraosseous lidocaine anymore. They suggest that an alternative such as intranasal opiates or intranasal ketamine should be used. Obviously, this needs a stable enough child. You have to weigh the risks of providing analgesia over speed, of course. Okay, so let's see our last topic, and therefore I also have an interactive online question. Do you think that intraosseous needles are MRI compatible? So can you bring a child who only has an IO line in to the MRI scanner safely? A is yes, B is yes, but only in a 1.5 Tesla magnetic field, and C would be no. So these are the possible answers. I'm curious about what you will vote on. And now we wait a few seconds until we reveal the correct answer. All right, so let's see what people voted on. It seems that it was a very controversial issue. Actually, I'm not sure who won, but let's see what the current literature says about IO and MRI. It's quite a new thing. So last year, the manufacturer of EasyIO managed to get FDA clearance and issues a statement about these needles. And according to them, and according to this PDF, which I highlighted here below this QR code, they say that EasyIO needles are so-called MRI conditional, which means that with certain conditions fulfilled, you can bring a child to or an adult to an MRI scanner. So if you have a child who only has an intraosseous needle in place, it's very well functioning and fixed, and this is and the MRI scan is urgent and is indicated, then you can bring this child to the MRI. You only have to take into account one consideration. You are obviously not allowed to put in a needle inside the MRI scanner, because the device itself, it's not MRI compatible, but the needle itself is. So it's good to know that from now on it's a possibility, although I would every time I would consult with the radiographer and the radiologist on call about this issue. All right, so these were the points I wanted to mention and wanted to discuss. I'm open to questions, and these were my take-home messages. Peripheral lines are the commonest invasive procedure in pediatric healthcare, and at the same time we have a very high failure rate, so we always have to consider the options and use ultrasound with good preparation. Extravasation injury is unfortunately quite common as well. Prevention and early management, early surgical input when needed is key. And at last, we also discussed IO sizes, analgesia options, and MRI compatibility. So this is the feedback QR code, and here you can see my email. Please feel free to ask a question in the YouTube chat or through email. And thank you so much for your attention.